Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
Our next case is a 70-year-old current smoker, 50 pack years, diagnosed with a stage 1A adenocarcinoma on the right side. He has a prior history of a couple of cancers that were treated with surgery. One was a stage 1 adenocarcinoma on the left side in 2000, treated with a lobectomy, and a stage 1 adenosquamous carcinoma on the right side in 2015, for which he underwent a wedge resection from the right upper lobe. And I don't have details of this, but reportedly had significant comorbidities. Positive symptoms include worsening dyspnea beyond baseline, and performance status at this time is 2. Medical history is of uncontrolled diabetes, morbid obesity with the BMI of 40, uncontrolled hypertension, and COPD. And I mentioned the couple of prior lung surgeries, a lobectomy on the left, a wedge on the right. Current smoker, drinks a couple of beers per night. Before we turn to the questions, let's review the imaging and any other details. Dr. Ginsberg, if you can.
So what we're looking at is images from a PET CT and a CT. We see a small nodule that's about 1.3 centimeters in the right upper lobe in the perihilar region, which is FDG avid. And we see that on the adjacent axial next to the CT image, which demonstrates the avidity, and also on the coronal image. So this looks like it's a localized single avid nodule with no other distant metastases seen.
Okay. Just a little more on the details of the workup. In early October, surveillance chest CT showed this new 1.3 centimeter right upper lobe perihilar nodule, followed by the PET CT that we saw. And the pathology shows a TTF1 positive, NAPSIN-A positive adenocarcinoma. A 4R node was insufficient. And so if we go back, question is, this patient who has had a couple of prior surgeries and has a relatively small 1.3 centimeter confirmed positive adenocarcinoma now. Dr. Force, how much does the loss of prior lung parenchyma and the pattern of metachronous new cancers apparently factor in over, we're now looking at a 2021 year history. Do you approach these individually, or do you feel that after a couple that the preservation of lung parenchyma with radiation-based treatment is an increasingly compelling approach in a 70-year-old gentleman who may be at risk for a few more of these in the coming years to decade or two?
Yeah, I mean, I think if there was evidence of other early stage cancers, typically what we see is, multifocal lung cancer or ground glass opacities, then that would factor in. If there was nothing, if there were no other suspicious lesions, then yes, I mean, he has had multiple cancers and he could get more cancers, but maybe he won't. So I would still, evaluate him for surgery. Unfortunately, based on the deep location, it is going to require a lobectomy. And, the question is, what other lobe was removed before? Because if it was the middle lobe, which is the smallest of all 5 lobes of your lungs, then it's potentially, well, it's definitely less of an issue. If it was a lower lobe that was removed on his previous surgery, he would require the entire lung coming out, what we call completion pneumonectomy, because you cannot just leave a middle lobe in there. It's not big enough. It becomes non-functional. And I would not do that to him. He does not appear to be a candidate for that. He appears to be potentially a marginal candidate for a right upper lobectomy, but I would evaluate him for that. But like I said, if what came out before for his other cancer in 2015 was the lower lobe, then I would definitely refer him for radiation, because I would not put him through a completion pneumonectomy.
I think that the lobe that was removed was on the left side.
Oh, on the left.
Yeah.
So then it's just going to come down to his, his preoperative evaluation. So his lung capacity, and, potentially, even getting a perfusion scan. I mean, I think when I looked at it, it looked like he had some emphysematous changes in that upper lobe. And that's the one thing that often gets overlooked. The patient may not have the greatest breathing function, but if they have a lot of emphysema in an upper lobe where the cancer is, there might not be that much function to that upper lobe. And in fact, sometimes we even achieve a dual kind of benefit where we almost do what's called a lung volume reduction.
Right.
We won't get into all that, but you actually improve some patients' breathing capacity by removing their lobe, because you remove the most diseased lobe. So this patient, likely is not going to have normal lung function. So they probably would get that perfusion scan, so I could see how much lung function am I truly removing, because it may not be as much as we think.
So that's kind of the definition of less is more, where they don't even have a functional deficit potentially even after losing that lung parenchyma, depending on the path.
Correct. And occasionally they'll even be, you improve their breathing capacity by taking it out if it's severely emphysematous.
Dr. Robinson, what are your thoughts here? I mean, I see the location and the size of this as, one that would be very conducive to a radiation-based approach. Is this one where you would be inclined to say, even if you can do surgery, it's questionable whether you should, and that this is arguably tailor-made for radiation given the size and prior loss of lung parenchyma? Or does that concept of lung volume reduction have much sway that makes you think that surgery is a strong option potentially here if the VQ scan suggests that?
Yeah, I think surgery should always be considered as an option. I would say that, in contrasting this to some of the other cases, so we had one which was a nice peripheral low-grade adenocarcinoma, which is definitely in our wheelhouse and will do very well. We have patients with larger squames that don't do quite as well. This is one where the location does start to impact it a little bit. It is getting more central. It's certainly not ultra central. We'll modify the dose and fractionation a little bit, but nothing that would make me quote lower local control rates. But the toxicities that we think about are different. So when I talked about the ILD patient, pneumonitis was the primary concern. Paradoxically, when you start to get people with worse PFTs and more obvious COPD emphysema, they actually have less pneumonitis. You need pneumo to get pneumonitis. So, but then here the toxicity profile is a little bit different as we start to approach doses that are going to be getting near the bronchus and the vessels as well. That's something we'd want to consider.
Okay. Any other comments?
I was just going to point out to Seth, as surgery is contemplated, some of the factors you mentioned about this patient do raise concerns: morbid obesity, uncontrolled diabetes. Even if the patient is anatomically resectable, those two conditions may definitely be an additional challenge when it comes to making that decision to go for an operation.
Okay, so I would summarize by saying that this patient does not have, is not categorically not a candidate for surgery, despite the loss of prior lung parenchyma and a couple of other surgeries going back to 2000. But with the comorbidities and with the loss of lung parenchyma, that is something that really needs to be factored in. Ideally with additional imaging to clarify the pattern of lung function. A ventilation perfusion scan could clarify, and if it suggested significant emphysema in the right upper lobe, in the apex, it's possible that surgery could actually be helpful, or at least not a hit on lung function. At the same time, that radiation is absolutely a consideration, but not one that is completely trivial, given the location and the potential for radiation to leading to toxicities to adjacent structures, the bronchus, et cetera. It is something to be considered, but this is not a case where there is a clear path of one over another, at least not without further assessment from, say, the ventilation perfusion scan.
And just to add to that, and I think Dr. Robinson, would probably agree, the majority of patients that I see that I'm having them see the radiation oncologist, they are not clear cut, no, you can't have surgery. And what it really comes down to most of the time is the patient and their family making the decision that, I risk stratify them and tell them what their risks are. I have them meet with our radiation oncologist, they talk to them, and the patient, makes the decision. And I think that is a very, very common scenario that I see in almost every clinic I have.
I'd agree. I'd absolutely agree with that. And, for that matter, that's why, when, even though there is certainly enthusiasm for doing the right thing and running these trials, these randomized trials, comparing the two, even when we have the results from those trials, that will never just be the answer for all patients, right? It's always going to come down to risk stratification, some degree of patient preference. What it will do is the more data we have, it'll inform those models in a way that makes it easier to talk to a patient in less vague terms, and say something more specific, like in your case, there may be a small survival advantage associated with surgery for your lesion, but here are some of the balances that may go from one or the other. So I absolutely agree. It's always nuanced. It's never straightforward. And whenever it seems straightforward, it's actually never, it isn't.
So I think that's a really valuable conclusion, that in this particular patient's case, as in the majority, it is not clearly that one option is off the table, so to speak, but rather presenting the risk benefit and the potential advantages and disadvantages of each approach, and letting the patient decide after hearing that range of options which is a better choice for him.